Hello and welcome to this special session on pancreatic cancer from risk to recovery. আমাদের সাথে আজকে রয়েছেন ডক্টর মানস কুমার রয়, সিনিয়র কনসালটেন্ট সার্জিক্যাল অঙ্কোলজি অ্যান্ড GI HPB অঙ্কোলজি, এবং ডক্টর চন্দ্রকান্ত MV, সিনিয়র কনসালটেন্ট অ্যান্ড একাডেমিক হেড মেডিকেল অঙ্কোলজি ফ্রম নারায়ণ Tagore হসপিটাল, মুকুন্দপুর। প্রথমেই ডক্টর রয়ের কাছে আসবো। Dr. Roy, what exactly is pancreatic cancer? Pancreatic cancer অসুখটা ঠিক কি এবং অন্যান্য ক্যান্সারের থেকে এটা কিভাবে আলাদা? How is it different?
প্যানক্রিয়াস যে গ্রন্থিটা সেটা আমাদের স্টামাক বা পাকস্থলী তার ঠিক নিচেই থাকে। সো দ্য ফুড কামস ইনটু দ্য স্টামাক, তারপর ওখান থেকে ডুওডেনামে যায়, আর ডুওডেনাম একটা লুপ হয়ে লাইক এ সি, ওই লুপের মধ্যেখানে প্যানক্রিয়াস গ্রন্থিটা থাকে। এই দুটো কাজ জেনারেলি ব্লাড সুগারটাকে মেনটেন করা,
ইনসুলিন
secretion, and to produce enzymes to help the food digestion.
Right.
Now, the pitta nali, the bile duct, which carries the bile from the liver to the intestine, it goes through the pancreatic head. So, pancreatic cancer hole, the bile duct obstruction hoy, তার জন্য পেশেন্টের জন্ডিস হতে পারে। So, we are really worried about this jaundice. Okay? And for some reason, it's a very aggressive kind of a cancer.
I see. Okay.
And
In fact, we will come to that. Sure. We will definitely come to that. That needs to be discussed in a little more detail. Sure. The next question is for Dr. Chandrakant. What are the main causes or risk factors linked to pancreatic cancer? And linked to this, the continuation of the question, are there any lifestyle factors or genetical predisposition which can increase the risk?
Right. So, pancreas cancer, pan matlab all. Pancreas is flesh.
Yes.
So, pancreas means it is fleshy throughout. That is the name how it has come.
Okay.
This is not a common cancer. Like if you look into lung, breast, they are more common. But pancreas is a less common cancer.
Right.
But this is a dangerous cancer. I can tell you, one of the most difficult cancers to treat. So what are the causes? কেন হয় pancreas cancer? যেরকম for any cancer, there is no one cause. মানে অনেকটাই risk factors থাকে। 10% patients এ family history হতে পারে। Family history of pancreas cancer, colon cancer, breast, ovarian cancer, এগুলো যদি থাকে family, in 10% patients, you will have a family history. Family history is one of the non-modifiable.
Which is genetic predisposition, which you have no control over.
Yes, which you have no control, but you can get into some screening, which we will just discuss. Then, what are the other causes? আর কি জিনিসে আমার pancreatic cancer হতে পারে? As usual, obesity. যদি obese থাকে, that means it's a metabolic syndrome. যারা obese, ওনার hypertension থাকে, ওনার diabetes
থাকতে পারে,
and the lifestyle, like sedentary lifestyle, and the fiber, the fiber content in the diet is less.
Okay.
And you have a lot of high calorie, high fat diet, especially the processed meat is somewhat implicated rarely for this. This is implicated. Smoking is a biggest risk factor for pancreatic cancer, and alcohol causes something called inflammation. Alcohol is an insult to the pancreas.
Okay.
It causes an inflammation in the pancreas, and not a direct risk factor for cancer, but the probability of becoming cancerous increases with recurrent pancreatitis.
So, is there a threshold limit, like 100 grams or something like that?
There is no safety threshold for
So, one should
anything. Like either smoking or alcohol.
So, one should completely avoid alcohol to safeguard against pancreatic cancer, right?
pancreatic cancer, there is no direct
No direct cause, but it's one of the
but that is advisable to
Right.
avoid it.
Thank you so much. Right. Thank you so much. My next question goes to again Dr. Roy. So we often hear that pancreatic cancer is detected late. It's very difficult to detect in the early stages, and it is not very common that detection happens in early stages. So are there any early warning signs or any subtle symptoms which one should be aware of?
Generally speaking, as a rule, the observation is পেটের কোনো cancer, any cancer in the abdomen, generally is diagnosed rather late. Whether it's stomach or colon or liver. Because initial the symptom হয় একটু খিদে পাচ্ছে না, একটু অম্বল হচ্ছে,
একটু vague symptoms,
vague,
non-specific.
non-specific. You had some dietary indiscretion and you had some ombol and acidity.
Right.
You tend to ignore, you tend to take some pills. That is the main reason, I think, with my years of experience, why the disease is ignored.
Right.
That's why they come to us late.
Right. Okay. So there aren't any telltale symptoms which, like, this can be very non-specific, it can be acidity, it can be bloating.
No definite symptom as such.
Right,
But generally,
right.
patients tend to think that if there is, I don't have any pain, so I can't have a cancer. But pain is a very late symptom of cancer. Right?
Okay.
But in the pancreas, it's like a fish-shaped organ. It starts from the midline and goes to the left side. Now, the midline, the bile duct goes through that head of the pancreas.
Right.
So those cancers are picked relatively early because the patient gets jaundice.
Okay.
But the tumor on the tail of the pancreas invariably gets delayed diagnosis because there is no organ there, no symptoms, and most of the patients present to us when the disease has gone to the liver or somewhere else.
Has already metastasized.
And and one more is if there is a new onset diabetes.
Right.
Diabetes ছিলই না, হঠাৎ করে ডায়াবেটিস যদি ডাব্লিউসিএস হয় তাহলে আমাকে alert like that.
Absolutely.
Yes, a new onset, rapid onset of diabetes
Rapid onset of diabetes.
in an otherwise healthy individual. This is
Suddenly.
important.
Absolutely.
And as sir said, like any symptom that is persisting or worsening over a period of 4 to 6 weeks,
One should seek medical.
one should seek a medical help. Ignore করা যায়।
Or to change the pattern. Yeah. You have been having ombol for many years, but suddenly the pattern
changes.
Yes.
Right. Thank you so much. Thanks for that. So how is pancreatic cancer then diagnosed? I mean, what are the tests or imaging techniques which are most commonly used to diagnose pancreatic cancer? Api bolben?
Yeah, yes, fine. See, if the patient comes to us with jaundice, or as Chandrakant said, sudden diabetes, usually practitioners or physicians do an ultrasound.
Okay.
As a basic minimum we should do, and some tests like liver function tests.
Okay.
That will give us a hint whether the jaundice is due to obstruction or
তো CT বা MRI কিছু usually করে।
that's the latest.
প্রথমে একটা ultrasound imaging হয়।
Yes, the simple ultrasound liver function test will give us some clue.
Great. Okay. So next question to Dr. Chandrakant. Are there any recent advances in screening or biomarkers that might help detect pancreatic cancer earlier in future? অনেক কাজ তো এখন হচ্ছে এটা নিয়ে,
Right.
সো এমন কিছু কি আমরা
Correct.
বলতে পারি?
So problem হচ্ছে কি I mean the present once the symptoms are there, if you do an ultrasound at times may miss a small lesion.
Right.
আল্ট্রাসাউন্ডটা দুটো রকম করা যায়। One is trans abdominal ultrasound যা আমরা করি। If there is a suspicion or if there is a family history where you need to screen, we do something called trans-esophageal ultrasound. মানে esophagus থেকে একটা endoscopic দিকে
Right.
we can get an ultrasound probe and look into the pancreas because there you can see the pancreas in a more closer way.
True.
That is a one we can remember.
Right.
And very importantly, CT scan, that's something called as a pancreatic protocol CT scan.
Okay.
মানে প্যানক্রিয়াসের জন্য একটা সিটি স্ক্যানের একটা সিকোয়েন্স আছে, ওটা যদি করা যায় pancreas is situated in a very critical area. Critical in the sense it is nearly to the back of the abdomen it is stuck. You have got major arteries and veins nearby.
Okay.
Portal vein
Right.
is a major vein.
Okay.
And then you have major nerves, something called celiac plexus. They are the nerves of the abdomen. So pancreas is in a very critical location, and we need to see along with what is the relation to this along with other important structures. So I will be explaining surgery when to plan, but I'm just telling you. So we should use the CT scan liberally. Whenever there is a suspicion, get a CT, contrast CT done. Do not wait for the symptoms to be advanced. Get a CT done. It is not harmful to get a CT.
Right. Absolutely.
And there is a blood test called CA19.9.
Okay.
It's a tumor marker.
Okay.
এরকম নাকি usually it's less than 35. এরকম নাকি বেড়ে গেলে ক্যান্সার না, but if it is increased, then you can do an imaging and see what is happening. It will hint you. It's simple blood test.
It'll give you a hint.
Yeah.
Clue দেবে।
যদি খুব বেশি বেড়ে থাকে তাহলে প্যানক্রিয়াটিক বিলিভিতে যে কোনো একটা, মানে it need not be cancer, it can be infection, inflammation, anything. You can do an imaging and see. So a blood test called CA19.9
Right.
have a low threshold.
That's a biomarker. That's a biomarker.
That's a tumor marker.
Tumor marker.
And then have a CT scan, and endoscopic ultrasound picks up smaller lesions also.
Okay.
Now coming on to biomarker. Biomarkers in pancreatic cancer. Biomarker mane ki gene? Which is the gene that is the culprit in pancreatic cancer? The culprit gene in majority, 90% of times, is a gene called KRAS oncogene.
Okay.
The KRAS oncogene ki kore? It makes a cell multiply without a growth factor stimulus.
Okay.
Normally, shorirer moddhe, when a cell has to multiply, there has to be a growth factor stimulus outside.
Right.
Kintu KRAS oncogene jodi activate hoye jay, without a stimulus, uncontrollably this cell starts multiplying. Now, a KRAS oncogene, KRAS oncogene, targeted jonno, we have got a lot of molecules that are coming up. In near future, I think we are very positive that these molecules will change the way we look at pancreatic cancer. There are a lot of molecules coming up. They are getting approved in the later line setting, in advanced stage.
I get that.
But because their side effect and they're not so efficacious, we are not able to get into the earlier lines. But there are new drugs that are getting approved. They're in the clinical trial phase. Probably if you would do an interview couple of years later, these drugs would have sort of changed the landscape of pancreatic cancer.
হ্যাঁ, না আমি এটা কি তাহলে বলা যায় যে ফিউচারে এত কিছু নতুন টেস্ট আসছে এবং there are new lines of new techniques of screening যেটার মাধ্যমে আমরা আরো আগে প্যানক্রিয়াটিক ক্যান্সার ডিটেক্ট করতে পারবো? Is there any hope like that?
Right. Detecting early is a challenge. Yes.
It still remains a
It
challenge.
still remains a challenge. But there are some very early reports where you do a blood test and say, is there a cancer in you or not? They are very early.
Liquid
biopsy.
Right.
They're very early in clinical trial. Right now, this should not be the message. একটা রক্ত সবাই জিজ্ঞাসা করে, আমার ক্যান্সার আছে না, একটা রক্ত পরীক্ষা করে বলে দেন না। এরকম এখনো কোনো পরীক্ষা নেই। Hopefully, in a couple of years, we will have something.
We will park that question
Yes.
for the moment and we will come back later on.
Yes.
Great, wonderful. So next questions again for you, Dr. Chandrakant. So once the patient is diagnosed with pancreatic cancer, what are the treatment options available right now at this point?
Right. Pancreas, it's an organ that is resistant to chemotherapy and radiotherapy.
Okay.
Pancreas, basically pancreas cancer arises from the duct. Duct is a pipe through which the juice flows.
Right.
It is tightly packed in the flesh.
Okay.
Whatever chemo or even radiation you give, there is so much of flesh. The flesh will prevent the drug to enter into the cancer cell.
Okay.
সেই জন্য আপনি even if you give whatever dose of chemo or radiation to that extent,
It doesn't help much.
it means it is resistant. It
Okay.
won't go away.
Okay.
So I can tell you, in the present day, mainly the curative treatment for pancreatic surgery,
Surgery.
even today, যদি সার্জারি না হয় রেডিয়েশন কিমো এগুলো করি,
Right.
but with radiation chemo we are able to cure a very small
Small
percentage
percentage.
of patients.
I understand.
Whereas if you put surgery is the answer for pancreas even till date.
Right.
So surgery আমরা চেষ্টা করব when the pancreatic cancer is there, stage মানে যদি কোথাও ছড়ায়নি, then I always go to Dr. Manas and say, sir, কিছুটা করে এটা অপারেশন করে দেন।
Great.
অপারেশন না করলে তো it is very difficult to cure this disease.
Actually, my next question was related to that. I'll come to Dr. Roy. তাহলে ডক্টর চন্দ্রকান্ত বলছেন যে সার্জারি ইজ দ্য অনলি ডেফিনেটিভ কিওর অ্যাজ অফ নাও। তো সেক্ষেত্রে আপনি একটু বলুন আমাদের অডিয়েন্সদের জানার সুবিধার জন্যে যে হোয়াট ডাজ প্যানক্রিয়াটিক সার্জারি এন্টেল অ্যান্ড হু ইজ অ্যান আইডিয়াল ক্যান্ডিডেট ফর ইট?
প্রথমে আইডিয়াল ক্যান্ডিডেটকে বলে দিন। দ্য ফার্স্ট ইজ পেশেন্ট হ্যাজ টু বি সার্জিক্যালি ফিট।
ওকে।
যেটা বড় 5-6 ঘন্টার অপারেশন বা কমপ্লিকেশন থেকে হ্যান্ডেল করতে পারবে। হ্যাঁ, পেশেন্ট হ্যাজ টু বি ফিট, হার্ট ভালো, লাংস, কিডনি।
ওকে, ভাইটালস গুলো সব ঠিক আছে।
আর সবসময় আইডিয়াল কন্ডিশন হয় না, বাট উই ট্রাই টু অপটিমাইজ। নাম্বার 2, যেটা চন্দ্রকান্ত বললো, সিটি স্ক্যানে যেন রোগটা কনফাইন্ড থাকে টু দ্য প্যানক্রিয়াস।
রাইট।
যদি ছড়িয়ে গিয়ে থাকে তখন উই শুড নট রাদার।
রাইট।
আর যদি একটু ছড়িয়ে গিয়ে থাকে তখন ইউজুয়ালি ওরা chemotherapy দেয়, নিউ অ্যাডজুভেন্ট chemotherapy,
Right.
in technical words,
Right.
সেটাকে ছোট করে কয়েক মাস পরে we operate. Now for any cancer surgery, the basic philosophy হচ্ছে to take out the tumor with the surrounding nodes, and আমরা যেখানে যেখানে অপারেশন করছি the resection margin has to be negative, মানে এদের মার্জিনে কোনো যেন ক্যান্সার সেল না থাকে। This is a universal truth for all kind of
cancer surgeries.
And the same thing adheres to
Total removal of the tumor.
Without touching it and without making any, leaving behind some pen. And but the difficulty of pancreatic surgery, যেটা ও হিন্ট করলো, সেটা হচ্ছে pancreatic পিছন দিকে there are important
Arteries, right.
important veins. The vein takes the blood from the intestine to the liver, and the artery supplies the blood to all the intestine. So we cannot afford to damage them.
Exactly. You have to protect those
Structures.
blood vessels and then to conduct the surgery.
So now the surgical techniques are improved. Amra vein take resect kore, we can stitch the vein.
Stitch the vein back
things
together.
I did not discuss is into.
I understand. No, shut up.
And arekta জিনিস হচ্ছে the difficulty for all kind of surgery is when we resect something, we have to reconstruct.
Exactly.
Right. So when we resect the pancreatic tumor, we have to আমরা স্টমাকটাকে বাদ দিই, বাইল ডাক্টটাকে বাদ দিই। These two are hollow organs. আমরা প্যানক্রিয়াসটাকে বাদ দিই। প্যানক্রিয়াস is a solid organ.
Right.
এই তিনটে অর্গানকে আমরা স্মল ইন্টেস্টাইনের মধ্যে আবার থেকে সেলাই করি।
Okay.
Now to stitch two hollow organ, it's very easy. So the bile duct and stomach can be stitched to the small intestine. কিন্তু প্যানক্রিয়াসটাকে যখন আমরা স্টিচ করি with the small intestine, and pancreatic duct, as he said, is only 4 to 5 millimeter. That is the trick.
That's the challenge. That's the challenge.
And that if that stitch leaks, which often it does, the pancreatic enzymes leaks out and it digests the body's own fat. So that is the Achilles heel of pancreatic cancer surgery.
So this whole reconstruction process is a challenge.
It takes time. Yeah.
Okay. Great. I'll come to Dr. Chandrakant. So we were talking about patients receiving chemotherapy, neoadjuvant chemotherapy, post-surgery. প্রথম কথা, এটা কেন দেয়া হয় and what impact does it have on outcomes?
যেরকম আমি বলছিলাম, pancreas is a tightly packed tissue.
Yes.
usual chemo doesn't enter. To bypass this, what we have done is we have got something called nanoparticle or albumin bound. এটা যদি করা যায়,
Okay.
আরেকটা হচ্ছে liposomal formulation. এগুলো মানে we are trying to reduce the size or bind with the protein. এটা যদি করা যায়, this chemotherapy enters into the pancreatic cancer cell.
Okay.
So this is the technology in chemotherapy advances we have. Make it small, nanoparticle, or an albumin bound, or a liposomal formulation.
Okay.
These have shown good efficacy in pancreatic cancer.
Okay.
স্যার আমরা যেরকম বলছিলাম কি make it operable. Operation করার মানে if it is little large, it is pressing on an artery or a
Right,
vein
right.
where I cannot operate.
Right.
We give chemo for 2 months.
So that it shrinks.
ছোট্ট করে যদি অপারেশন এটা আমরা বলি borderline resector.
Okay. Okay.
Then we make it shrink and we try to operate.
Make it operable.
Yes. Operable is the key to success.
Right.
So we give good amount of chemo, little bit higher doses we give.
Right.
Every 15 days or 4 to 6 cycles, 2 to 3 months treatment. And then you will see the scan, it shrinks, operate. It's wonderful. If you are not able to operate, then we are left with radiation. Radiation, the problem is radiating pancreas, you get a lot of hollow organs in front. So you should have a technique where you spare the normal organs and radiate only the pancreas. So that is something like called as a image guided or an intensity modulated radiation. If you can do
It has to be focused only
yeah,
on
only focused on that, avoiding radiation to
other organ.
So with this, we are able to get. So to add more onto this chemotherapy option, there is something called immunotherapy that has come up well. But immunotherapy works in less than 1 to 2% of pancreatic cancer.
Okay.
It's like a lottery. এটা যদি পজিটিভ হয়, then immunotherapy works really well. ওটা বলি আমরা MMR testing. ওটা যদি পজিটিভ হয়, then immunotherapy can be given.
Can be given.
But in 90,
Very small
90
percentage of patients.
only chemo.
Right.
Small percent, some chemo or some immuno or target therapy may be offered.
Okay. Okay. Thanks for that. Next question also for you, Dr. Chandrakant. So, pancreatic cancer has a reputation for being aggressive. So, what are the factors which can influence survival rates or prognosis? And are the outcomes improving with the new treatment approaches which are getting available right now?
Right. So, we diagnose pancreas in a little later stage. But now the awareness is much. CT scans are available more rampant.
More rapidly.
People are doing CT scans and we are trying to get a curative surgery for majority of them. And the surgical advances also have improved. And the chemotherapy, immunotherapy targets, they have actually added life. I mean, not that one modality has changed, but all of them.
Combination of the new
Combination of them,
approaches.
Like one drop of benefit has sort of increased the survival of pancreatic cancer, but still a long way to go in this space.
So, কোনো একজন পেশেন্টের পক্ষে কি এত মানে a combination of therapies receive করা সম্ভব? Is it possible? Sometimes do you use a combination of therapies
We do.
on one patient?
We do use.
Okay.
We do use surgery and followed by. And then if there is a requirement, we add radiation also in these patients.
Okay.
These patients do good. Like those who can tolerate these treatment,
Right, right.
get it operated, they do good. It is possible.
So the new approaches are giving hope to the patient.
But a long way to go.
Still a long way to go. Still the beginning. Okay.
Can I buttress for a minute?
Please.
If you look into the history of pancreatic cancer surgery and how it has evolved, it's the most important thing, the jaundice. So jaundice hole blood ta clot korte pare na.
Okay.
So when the vitamin K was discovered, injection vitamin K, so jaundice se blood for it helps the blood to clot in jaundice patient.
Okay.
That helps the development of the pancreatic cancer surgery. He said, no, every little thing helps.
So that was a key milestone.
It was same. And then other thing is important, which we laugh these days, which might laugh, is the blood bank facility. You know, the blood grouping 100 years ago. But that helped progress pancreatic cancer. Then the stitching. Nowadays we use sutures which are as thin as your hair. Those things were not there when I was trained 30 years ago.
Right.
So there's 5-0 proline, the loops.
All surgical accuracy এখন অনেক better হয়ে গেছে.
So vitamin K, the blood grouping, cross-matching and the suture technique, these three are important milestones in the development of the pancreatic cancer
treatment. Wonderful. So the final question is, this is basically a key takeaway for the audience. That is finally, like, what steps can people take to reduce their risk of pancreatic cancer? Dr. Roy, you can answer that. And what public health measures can help in earlier detection of pancreatic cancer? Duto question actually combined.
See, it's like any other cancer. No, the real cause is not really known. It's just, honestly speaking, just a bad luck.
True.
Some gene undergoes a mutation. You may not have touched alcohol. You may not have smoked a cigarette.
Still, you might have cancer.
So that's why people ask us, Amar Kano, why did I get the cancer? What keep up with? No, it's not pap. It's just bad luck. But then, as Chandrakant said, there are certain modifiable risk factors, like, we should not smoke. Ideally, we should not touch alcohol. At least obesity we can control.
Have a healthy diet.
And as far as public health awareness, I think the government has to take some steps in spreading the awareness of
general awareness is the
good health. Like as you said in the very outset, the incidence of pancreatic cancer in our country is 1 per 1 lakh population. So we can't have a screening.
So incidence is
very low. Very low. General awareness, more ultrasound or CT has to be.
Okay. Thank you so much, Dr. Roy. Thank you so much, Dr. Chandrakant. I hope our audience today will find some key takeaways from this session. And although it's not a very common cancer, it can be really deadly and it's very aggressive. So we will soon come back with our next episode. Thank you so much.